first thing I want to do is welcome you all to the virtual ethics rounds. And the second thing I'd like to suggest is for people to turn on their videos. That would help me out because I get, believe it or not, feedback from watching your expressions, hopefully your smiles, and this way it's more of a two-way conversation. And actually, that reminds me, this is I like this to be as collaborative as possible. So write something down in the chat, and I'll try and say it, or better yet, unmute yourself. Stop me at any time, at various times. I'll ask people to tell me what they think, and we'll have some polls, blah, 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 all that good stuff. Okay, great. So having said that, so this is sponsored by the Ethical Advisory Committee. We have consultations 24/7, and you could contact me. This is my phone number, and you could place an order in Epic, or better yet, Doc Hale or me. By the way, I am recording this, and I'll show you about that, where you could find the recording. And if you say something that you don't like, just give me a call and I'll edit it out, no problem. So regarding CME, we have a new system. It's one credit, and to obtain credit, you register once at this site here, and that's good for the rest of the year. And then you could enter this code on your cloud CME on your cell phone if you have downloaded that app already. So any questions, just send me an email after the presentation. So the objectives of this activity, CME activity, is to discuss ethical dilemmas in clinical practice and explain how to use an ethical framework for solving ethical dilemmas. And actually, we'll do that. We'll see how we could solve these ethical dilemmas. So regarding the taped presentations, you go to the intranet and you click on physicians. You could also, I don't have it here in the search box here, you could type in EAC, and then you get to this screen here, and we have something called Ethics Lunch Rounds presentations. I used to serve lunch, and hopefully one day, if enough people get vaccinated, we'll have the lunch rounds again. So let's see now. Any questions about anything what I just said? Okay. I appreciate having about 8 people showing their videos. Again, if more people want to show their videos, again, that would help me out. Okay, so let's start with this first case. It's and let me just keep track of the time. All right, so the first case is, should a patient who is a undocumented immigrant receive a lung transplant? So, okay, if you're not talking to me, mute yourself. How's that? That's rule number 4. Okay, great. So patient is a 59-year-old woman with past medical history of diabetes, hypertension, hyperlipidemia. In August, she presented to the emergency department of Southern Maryland Hospital Center with 3-day history of fever accompanied by worsening cough and shortness of breath. She had multiple known COVID positive contacts and subsequently was found to be COVID positive herself. Subsequently, she went into respiratory failure, was transferred to UMMC and put on VV ECMO. Okay. Let's see now. Hospital costs, complicated by all the usual stuff, including CRRT and CRRT clotting. She's currently on the vent, ECMO, CVVH, and trying to wean down the sedation. She continues not to make any improvement whatsoever on the ECMO, and the thought is that she will not be able to be eliminated from the ECMO. So the question is, should the patient be considered for a lung transplant? Well, why don't we do a body poll? How many people say she should be considered for a lung transplant? Raise your thumbs if you say yes, and thumbs down if you say no. Let me see. So I got a few thumbs down and a few thumbs up. Okay, so people are showing their jaundiced hands. That's good too. Okay, so actually, I'm seeing 65% are saying yes. So let's well, what to do now? So let's do an ethical analysis. So here are the competing ethical principles. But before I show you that slide, why don't you either write in the chat box or unmute yourself and tell me the reasons to do the transplant. But why should we do the transplant? Or tell me the reasons not to do the transplant. What are the competing values here? Anybody would like to voice their opinion? Okay, we're having all humans deserve life-saving medical care despite immigration status. It's worth a shot. Commitment to caring for others. Principle of beneficence. She is young. Thank you very much for saying that. Relatively healthy prior to COVID. Okay. We took an oath. Yes, right. Okay. What about what are the reasons not to do the transplant? What is the big concern there?
What did he say?
Anybody? Will this preserve her life? That's always a good question. Any other reasons not? Okay, afford the anti-rejection meds. Who's paying for this? Okay, yes, right. That's a good question. Who's going to pay for this? All right, let me have if she could navigate the healthcare system, success rate. Okay, good. Some good responses. So here I have down here for the transplant, immigration status should not reduce the value of being human, medical profession obligated. As someone said, we took an oath. The principle of reciprocity, 3% of organs from deceased donors come from undocumented immigrants. Now, not in favor of a transplant. Some people say scarce organs should be reserved for citizens and legal status immigrants, and one should not exacerbate the organ shortage. Well, the person adhered to transplant care. Someone mentioned that. And of course, the big thing is, who will pay for it? Who will pay for this costly procedure? So having said that, here is the uninsured rates among the non-elderly population. We have 8% for U.S. citizens, lawfully present immigrants, 23%, undocumented immigrants, 45% are uninsured. So let's investigate the financial situation. So for sure, there's the EMTALA Act, Emergency Medical Treatment and Labor Act, in which Medicaid will, under federal law, hospitals are required to screen and stabilize every patient who seeks emergency care. So that means anybody who shows up in the ER will get treated, whether they have insurance or not, and Medicaid will reimburse the hospital for that. Now, undocumented immigrants are high risk of being uninsured because they have limited access to coverage options. Now, their uninsured rates reflect the limited access to employer sponsors, insurance opportunities, and the rules bar them from participating in Medicare, Medicaid, Children's Health Insurance Program, and the Affordable Care Act. Even DACA's status in most states cannot get the insurance. Now, there are some possibilities. They could get coverage through their employer or as a spouse or dependent of an employer. They could purchase private insurance, but that could be very expensive, and some states could cover students through their health programs, and undocumented immigrants could obtain low-cost care through some community health centers, but it's often limited. So now in Maryland, to be able to be insured by Medicaid, you have to have a certain immigration status that's listed here. So refugees, asylum status, and these other conditions. So if you have this immigration status, you could get Medicaid. So now, there are pathways to obtain legal status for undocumented immigrants. So first thing one could do is marry a U.S. citizen, and that would be a legal pathway. Dreamers who received higher education, in which case the U.S. employers, if they want that person to, if they want to employ that person, they could sponsor that person for a green card, or the person could apply for asylum status if that is relevant. The last pathway is to apply for what's called a U visa. So if you've been a victim of certain crimes and you aid the law enforcement in capturing the person who committed the crime, you could obtain legal status. Now, this next slide shows all the qualifying crime activities that if you're a victim of any one of these crimes and you aid in the capture of the criminal, you could get legal status. Now, I have one question. It says here, if you've been a victim of a murder, I'm not quite sure how you could aid in the capture of that criminal. But anyway, I'm not a lawyer, so let's move on. So now, regarding kidney transplants, actually, the financial picture favors a kidney transplant because the cost for emergency room dialysis, it's much greater than being on a scheduled outpatient dialysis, and outpatient dialysis is even more costly than a transplant. So with kidney transplants, it makes financial sense to give the immigrant the transplant. And actually, a lot of states are now, where did I have that? Yes, right. In Illinois, they passed a law saying undocumented immigrants could receive a transplant, and so far 200 undocumented immigrants in Illinois have gained access to kidney transplants. Now, let me skip that slide. So let's continue with our case. The social worker spoke to the patient's daughter to clarify her mother's legal status as an immigrant. And even though she's been here for 14 years, she doesn't have a green card and never had health insurance. And at this time, she may qualify for emergency medical assistance under the EMTALA Act. But this case manager contacted the MA office to inquire about the emergency medical assistance, and they said they will not cover a lung transplant as it is considered an elective procedure. So I'm not sure about that. The patient is on ECMO, and if she doesn't receive a lung transplant, she will die. So I'm not sure what's the definition of elective in this case. So we may need to petition Medicaid for further clarification. Now, when this case came to the ethics committee, we were asked whether further treatment is futile. She was turned down for the lung transplant because of cost, and essentially all further treatment is now futile. Seems a little bit odd that because she was turned down for the lung transplant, that now all further care is now futile. I have to continue to wrap my head around that concept. But anyway, they had family meetings, and the daughter said, did not want to remove her mother from ECMO because she said, we are Christian and we cannot make a decision to end her life. However, a few days later, when the patient was deteriorating, she finally consented to withdraw ECMO ventilatory support, and the patient died shortly later. Now, we had several sessions
that blows my mind.
with the staff regarding this case, and there was a lot of moral distress with the staff taking care of this patient. You take care of a patient for 6-8 weeks, and then because of financial reasons, she expired. And you put in all that energy, that emotional energy, empathetic energy, and a lot of people had a lot of distress. I, from a previous case, that involving a lung transplant, I realized that the hospital has a financial bucket for charity care. And so I approached the hospital with some other individuals, vice president for Transplant and head of social work, and one of the financial people in the hospital, and we discussed the possibility of funding lung transplants or any solid organ transplants for undocumented immigrants. They looked at their protocol book and saw that lung transplants or any organ transplants for undocumented immigrants are not prohibited. So essentially, the hospital said they would consider providing financial support for the transplant and for the post-op period as well for the medications. So that is obviously a wonderful thing, and we are trying to develop criteria for who would qualify to get a lung transplant. Obviously, good likelihood of post-op survival, maybe a criteria for long-term survival, a state resident, a supported psychosocial structure, absence of a drug use disorder that cannot be treated, encourage living donation for renal transplants, and something that may or may not be on the list is the prospects for some contribution for financial aspects in the outpatient setting, for example, investigating charities in the community, employer insurance, but the major thing is that it is now a go, and that we would give transplants to undocumented immigrants. And I meant to pull up that now Biden is thinking about providing a legal pathway for undocumented immigrants. So if that comes through, then these individuals would be eligible for Medicaid. Any remaining thoughts?
I have a thought. My name is Yasmin. I'm a PGY1 at Midtown, going into radiation oncology. So there are loads of people who have insurance in the US, but they have really bad insurance, where even though, you know, they have quote unquote insurance and they fall into the insured bucket, they're still left with bills that are thousands of dollars. And so if we're paying for undocumented immigrants and essentially just paying for everything, then how are we also going to help the people who are documented who just can't afford to have better insurance? I mean, why pay for everything for one person, but then leave someone else with a bunch of bills just because they quote have insurance?
Well, that's a good question.
Yeah,
The fairness, how do you ensure equity among all the participants? And I don't have a immediate answer to that. How do you fairly distribute the available monies? And that's going to take some kind of ad hoc committee to look at all the different angles and see how one could distribute fairness or have a fair distribution system. That's good question. Thank you. All right. Any other difficult questions that I can't answer? All right. Very good. Okay. Good. So let's keep on tracking this issue. All right. So let's go to the next case. Help with discharge planning. So this is a patient from the NICU, and I see we have several of the providers from the NICU. So please feel free to unmute yourself and add any of your comments. We have a baby girl, 38 weeks,
that was gonna happen.
born in August, and with an autosomal dominant neurodegenerative disease, chromosome abnormality 15.9 MB 2Q24.1. I'm sure you all know what that is, she has been in the hospital for about 5-6 months with recurrent lactic acidosis, white matter disease on the MRI, and multiple congenital abnormalities, and also a VSD. She early on developed hypoxic ischemic encephalopathy and hemodynamic instability and respiratory failure requiring intubation and also seizures. She remains critically ill with acute chronic respiratory failure and requires monitoring for a host of clinical issues. Most distressing is that she remains continually agitated, and she's on a host of sedatives. She's always crying. She's not consolable, and that is causing a lot of distress. Moral distress suffered by the staff because the child is continually agitated and is resistant to being consoled. The parents, who are Spanish speaking, initially thought of taking the child home, but now feels it would be overwhelming for them, especially since they have other children in the household as well. The baby, so the question is, where's the next place for the baby to go to, other than the acute care hospital at University of Maryland? Now, the baby was denied admission to the hospital for sick children in Washington due to continued medical instability, and she was initially considered for home hospice by the Chesapeake Hospice entity. However, the parents refused DNR status because their goals of care was not synchronized with the goals of care of hospice. So we're still left with where does the patient go? We did an ethics consult, and we our recommendation: patient with poor prognosis, estimated will not live beyond 1 year of age, which the parents realize and accept that prognosis, options for out-of-hospital transfer are limited, and it appears that maybe inpatient hospice may be the best alternative, but that's probably not available. So we recommended to further explore with the parents the understanding of DNR and her current medical condition, which includes continual agitation. And we wanted to set up yet another family meeting to discuss reasonable goals of care and discuss maybe inpatient hospice. So we had that meeting with the whole team and the parents, mom and dad, and we wanted to explore the family's understanding of the child's condition and determine realistic goals of care. And when we asked the mom about the goal of care, and she actually said, we want her to get better, to take her home. Now they want to take the child home, and we discussed that it is also our hope for you to take your child home. However, in the last few weeks, her condition continues to get worse. And we also discussed about the baby's agitation, and it appears that she might be suffering even despite all the sedative drugs that we're giving her. And even the mom said that when she goes to pick her up, that the child is agitated and sweating, and she's actually somewhat reluctant to pick up her child. So we said our belief is that the patient is suffering, and it's quite possible that even despite optimal, maximum efforts, she may fail to improve. And the mom said, well, if it comes to that, she said she'll be comforted by the fact that everything has been done, and she will accept God's decision and pray that her child will go off to a better place. And I said that in the next few weeks, we hope the child improves. However, if she continues to need high doses of medications without improvement, then we will need to reassess our goals of care and consider what would be in the child's best medical interest. I essentially said, we said to the family, we will need to have another conversation. And so essentially, what kind of help us out now? Let's say the child doesn't improve and she remains continually agitated. What kind of conversation should we have with the parents? Feel free to unmute yourself.
I think a discussion comparing the inevitability of the child dying against prolonging suffering while she is alive is the best prospect to try to get on the same page with them.
So I'm sorry, so you would discuss with the parents
the fact that the child is suffering and that continued care the way it's going is prolonging suffering and is not going to be able to keep the child from dying. It's just going to be a longer, more miserable existence until that happens.
Okay, all right. And if the parents keep on saying, well, we want to continue on.
Well, I think then there are really only two options. One is to continue with the parents' wishes. The other would be to pursue legal recourse through the court system, that this is care that the physicians and staff feel is futile, and is against the child's best interest, and seek permission to discontinue the life support.
Okay, all right. Good, thank you. Other thoughts? So there is a Maryland law that defines futility, and it says that docs are not obligated to give treatments that they believe to a reasonable degree of medical certainty will not prevent impending death or will not prevent the further deterioration of the health of the individual. And if you have two physicians document that, then one is not obligated to perform CPR. And if the surrogates refuse, they have a right to transfer, which obviously is not going to happen here. So every hospital have a different policy to follow that process of determining when treatment is medically ineffective. So one could go down that route without going to court. And one could also put on the table about escalation, no escalation of further treatment. Now, you mentioned about discontinuing the life support. That does get a little tricky. That's not the right word, but it gets a little bit. It's in another territory from saying we won't do CPR. Other thoughts?
Hi, it's Carol Green. I'll save you trying to read what I wrote. I think it was September that I last met with the family because there's very little more that genetics has to offer here. We have a clear diagnosis of a progressive neurologic disease in addition to her multiple malformations. So they're separate disorders. And the family understood this and listened to us respectfully and still wanted a trach. And I can promise you, without going back to read all the notes, that the NICU has absolutely talked with this family about the baby's suffering, and that the family, what you showed on the slide, Dr. Silverman, shows that the family does not see any internal inconsistency in their statement that they understand she's going to die, but they want her to get better enough to go home, but they aren't capable of taking care of her at home, but they want her to be better enough to come home. We all see the internal inconsistency, and they don't.
Well, I agree with that, and that's why I say that when we talk about goals of care, we have to talk about realistic goals of care. I agree. Having a goal of taking the child home is not realistic.
Unless it's home with hospice to die, but the family doesn't accept that as an option, so we're stuck.
Right, yes. Well, I agree, and that's why I'm saying that what to do now. We could continue with the current treatment. I don't think that's a good option. We could remove life support, but that's going to cause a lot of emotional distress. I think we should invoke DNR and no escalation of further treatment. I think the in this particular case, the suffering is if you balance the principles, on one end we have family autonomy versus, and we have here on this side prevent suffering, and I'll use the word dignity, human dignity, and then you could put other stuff here: moral distress of the staff, justice. I think as compassionately as possible, we should try to move forward with this sad case in a empathetic, compassionate way. So we'll see what happens. We'll maybe in a week or two have another discussion with the family. I like to think at the last family meeting, we kind of like laid out the groundwork. So we'll give you feedback on this case. And any other comments from the NICU staff? Okay, very difficult case. All right, so let me.
Just from the NICU staff, we just as a group wanted to mention that she's like intermittently really agitated like that, and it's just a cyclical pattern. So I think it's been harder for the parents because she goes through periods of time where she seemingly looks comfortable, and then it will last a little while after we escalate her sedation, and then she goes back to being super agitated. And we think she might be like neurostorming or something. So we're trying to help with that, but I think it's hard when she doesn't look like she's in distress for the parents to see, even though she's still requiring all of the other equipment and support. I think it's complicating things because when she's not agitated, she looks like, she's just laying there sleeping like a baby. So I think that's also complicating things. But
and she also has no IVs or anything like that. She's on full G-tube feeds and vented trach, which we don't often change her trach settings, except for when she has her little crisis moments. But
Relatively stable.
Yeah, she's relatively stable on that. Just doesn't tolerate a long-term vent for home use.
But it doesn't change her prognosis at all.
Yeah.
We just wanted to mention that just to give a whole picture. But
And her condition. Okay, so we'll see. Let me end with a brief case. Should the patient be compassionately extubated at the request of his brother, who's the healthcare agent? So just really quickly, this is a 56-year-old male with a history of lung cancer, status post left pneumonectomy in 2018. He gets admitted with he came in complaining of not feeling well and some melena, and at 10 p.m. he was noticed to be short of breath, satting at 90% with an SPO, satting at 90%. He was put on 2 liters that increased to 95%. This patient has an altercation with a nurse and wanted to leave AMA. What do you think? What to do now? A body poll. How many people say yes, leave AMA? Let me look at your. How many people say no? Okay. What should we do now?
Is he competent, capable to make medical decisions?
Okay, good question. So the patient, ANO times 4, and he said he would come back the next day for his chemotherapy appointment, and he was deemed to have capacity to leave. Well, the residents called me up in the evening and asked me, should we have the patient leave AMA? And I think I did the very first telehealth determination of capacity over the phone. And I said, absolutely not. This patient sounds like he doesn't have capacity. And half an hour later, he got more short of breath and eventually experienced a PEA arrest and had to be intubated. Now, the next day on rounds, I was told that he has a living will, and the living will said, I choose not to prolong life if I have an incurable, irreversible condition that will result in my death within a relatively short time. Or if I become unconscious and to a reasonable degree of medical certainty, I will not regain consciousness, or the likely risk and burdens of treatment would outweigh the expected benefits. So let me ask you, how much guidance does that instruction in a living will give us? Does it help us out on what to do? That instruction? Yes?
Some time, because we're not sure if it's irreversible at this point.
That's right. And incurable, irreversible. So, right. So this is not relevant. Now, with an advance directive, the most important thing is appointing a healthcare agent. And it says, my agent shall make decisions for me in accordance with any instructions I give in part 2 of this form, which was, this was part 2. And my other wishes to the extent known to my agent. And if my wishes are unknown, agent shall make healthcare decisions in accordance with what my agent determines to be in my best interest. So what's the next thing to do? This is not a trick question.
Find the agent.
Yes, right. Find the agent. Well, that wasn't too hard. I had a phone conversation with the brother, and the brother said, listen, this patient has a horrendous quality of life with his cancer, smoking, and severe drinking. And he said he didn't go to the ED for treatment. He wanted pain relief. He wanted all this suffering to end. And he said he had multiple conversations, and I know what he wants. And I said, The brother said he had wanted to leave the ER because he wasn't seeking treatment. And I told him, well, actually, he wanted to leave because he had an altercation with the nurse. And I said, listen, his prognosis is poor, but he has made some improvement during the last week. So maybe give it a few more days to see whether he could regain his capacity. And I said, well, listen, why didn't you come in with your other brother and we'll have a face-to-face discussion. And essentially, well, on the table, what to do now would be continue with current treatment, comfort measures only, guided by the previous conversations, and also include compassionate extubation. So we had a meeting with the two brothers, and both brothers said, listen, this patient would not want to live this way. And I said, well, listen, the patient is now on minimal support. His oxygen level has gone down. All sedation has been discontinued to try to wake him up. And something actually that I didn't know when I spoke to the brother first was that the resident told me that when the patient became severely short of breath, she had asked him about intubation, and he said, definitely yes, I want to be intubated. I want to keep on living. And that was 30 minutes prior to his cardiac arrest. So when so thoughts about that? Should that be compelling? Should that be considered a compelling fact that he actually said yes? Was he, throughout these series of ethics lunch, just give me one more minute, and I like to say I'm going to try and have these sessions monthly, but one of the things I like to continue exploring is the determination of decisional capacity. So in this case, did he have capacity to say yes to intubation? He's short of breath, oxygen levels going down. Well, let me fast forward the discussion for now. I would say he had capacity to say yes, but I'll leave you something for the weekend. I would say he had capacity to say yes, but if he said no, I might say he didn't have capacity to say no, except for the fact that if you rang up his surrogate and the surrogate said no, then I think that would be in accordance with the advance directive. But right. So all I want to say, the importance of facts. Nowadays, we live in an era in which we don't know when a fact is a fact, okay? Wrap your head around that. And essentially, when we do ethical analysis, it's very important to gather all the facts, involve all the stakeholders, and balance the ethical principles. So the last thing I want to emphasize is that if you get all the facts, you may make another ethical decision. And when the brothers heard what they heard, they said, okay, let's continue for a few more days. This appears to be his wish, and that's fine with us. So again, the importance of gathering all the facts. I can't tell you how many times that you get one other fact that comes in to the conversation and you wind up making a different ethical recommendation. So right now, the patient is continuing to improve and he's waking up, and hopefully he'll be extubated in a few days. So help me out here. If he says, I don't want to be intubated anymore, just give me comfort care. So we should pursue that pathway. This is not a trick question.
Yes.
Okay, all right. I agree. I think that I mean, I would explore the reasons why he's saying that, but not a long and drawn out discussion. He has the support of what he was thinking about in his living will and the support of his family. So I'll give you feedback on this case as well next month. So any remaining thoughts on anything? All right, well, let me, I tried to increase the capacity of this event to more than 100. Apparently, that didn't go through. So next time, I'll make sure of that. But let me thank you for attending. And I'll quickly have this recording available on the Ethernet. And also, I'll send it out via email with a link to my Dropbox. So have a good weekend. Continue to stay safe. And maybe next time we'll talk more about vaccinations. And hopefully that will be a short conversation. So anyway, thank you again for attending. All right.
Thank you.
Okay.